So we have seen all sorts of macular holes being treated. So now let us look at management of the failed macular hole surgery. So before going on to what is failed macular hole surgery, what is a successful macular hole surgery? It is a closure of the foveal defect with continuous retinal layers and an intact ellipsoid zone of the photoreceptors. So this is a type 1 closure. Type 2 closure could be V-type or U-type. V-type, as you can see here, or a U-type where the edges of the hole is attached to the RPE, but there is a central foveal defect. It's a failed macular hole surgery. These such small macular holes tend to close from top to bottom. And so these small outer lamellar defects cannot be called a failed macular hole surgery because it might take long periods for it to close these defects. So being said, now failed macular hole surgery, it is assumed that adequate ILM peeling, as shown by Dr. Abhijit, has been done and adequate gas tamponade is given. So which are the ones which fail after the first surgery? Obviously, as shown, large macular holes like this, greater than 800 microns minimum hole diameter, chronic macular holes with RPE changes and such subretinal precipitates, myopic staphylomatous macular holes, and large traumatic macular holes. So now let us look at some of the techniques that is used for this failed macular holes. The first is the inverted flap technique. This is basically to prevent a failure of large macular holes. The simplest procedure is repeat fluid gas exchange done in early failure of macular holes. The commonest procedure is free ILM flap technique. And now people are using lens capsular flap transplant, and rarely in staphylomatous failed myopic macular holes, full thickness retinal free flap is also used in failed macular hole surgery. Rarely amniotic membrane transplant and arcuate retinotomies are also done to close the failed macular holes. So inverted flap technique is better to prevent the failure of macular hole surgery. So it was first described by Navraki. And in this technique, these ILM, which is multiple ILM flaps are taken from the arcade radially towards till the edge of the macular holes, and it is kept over the macular hole, because this ILM flaps not only acts as a scaffold for the migration of the Muller cells and closure of the macular hole, it also releases neurotrophic factors and helps in the survival of the retinal neurons and photoreceptors. So multiple of such flaps are taken, and these flaps are brought till the very edge of the macular hole, and then it is trimmed with low suction cutting, so that only the adequate amount to cover the macular hole is left. And after a fluid air exchange using a soft tip cannula, these flap is generally nudged to cover the macular hole, and a long-acting gas tamponade is given at the end of the procedure. So the simplest procedure being a repeat fluid gas exchange. As mentioned, early surgical failure, usually within the 2 weeks of surgery, if it's an inadequate gas tamponade or poor positioning by the patient, usually the fashion will be like this: a raised cuff of subretinal fluid and edematous lip of the macular hole. So these are examples where only a fluid air exchange and a longer acting C3F8 gas is used, and a type 1 closure of these macular holes have been achieved. So the commonest procedure after a failed surgery is taking a small flap from the edge of the already peeled area of ILM and placing it slightly larger than the macular hole diameter and putting it over the macular hole, so that again it acts as a scaffold for Muller cell migration. So this is actually a modification of this free flap technique, wherein normally perfluorocarbon liquid bubble is not used in the original technique, and here it is being stained. BBG staining is done under the PFCL. Why it is done is because after taking this flap from the already peeled area of ILM, the ILM is quite flimsy and light, so it will float around in the vitreous. So, and that is what makes this procedure a little bit difficult. So this modification of peeling it under the PFCL bubble and then just dragging it towards the macula, not lifting it out of the PFCL bubble. So this is the way to put it on the macula, and with soft tip cannula, I can gently nudge it to the macular hole area, and a careful fluid air exchange is done with low air pressure and taking out all the fluid above the PFCL bubble so that it doesn't cause turbulence and loss of the flap kept over the macular hole, and long-acting tamponade is given. A small modification of this technique is a hinged flap. Hinged flap is again to prevent the loss of this flap after keeping on the macula. It is hinged at the edge of the already peeled area of hilum. As you can see the clinical photo, it is kept over the macular hole before putting the gas, longer acting gas tamponade. So also now it is a common practice to do if it's a combined phaco surgery, or as in this case, it's a pseudophakic case. Pinching a small piece of the posterior capsule which is stained with trypan blue, and it should be slightly larger than the macular hole diameter. And if the point is to put a drop of viscoelastic outside so that it doesn't float like this in the vitreous cavity, though it is more thicker and heavier than the ILM flap, this can be kept over the macular hole, so that this also acts as a scaffold and happens to close the macular hole. And once it is kept over position, fluid air exchange is done, and gas tamponade is given. So as you can see here, after 2 weeks, the capsular flap is still there, and around a month later, almost a type 1 closure is achieved under the lens capsular flap. So here, since it's a combined phaco surgery along with failed macular hole surgery, after the capsular excess, this anterior capsular flap is preserved and kept moistened on a petri dish until you proceed with the phaco surgery, and then go ahead with the sclerotomies and do a fluid air exchange. You can hand fashion this capsule to a size slightly larger than the macular hole diameter, and put a drop of viscoelastic on this capsular flap before taking it into the vitreous cavity, and then go and place it over the macular hole. So as you can see here, it is placed over the macular hole with viscoelastic. It prevents from getting displaced during the gas injection or subsequent positioning of the patient. So here at the end of 1 month, you can see still it acts as a scaffold and allows the migration of Muller cells to close the macular hole. So an extreme procedure, but in refractory myopic large macular hole in a staphyloma situation, it's very challenging in a failed surgery to get this ILM flap again because of the extreme tessellation of the fundus. In such situation, from the supratemporal equatorial region under perfluorocarbon liquid, full thickness retinal flap is taken after cauterizing the vessels around it, and it is lifted and dragged under the PFCL so that the side of the retina should be correct when you place it on the macular hole. So you can see that a failed hole, and once the flap is kept over the macular hole, after 1 month, the tissue is taken up and there is a closure of such staphylomatous macular hole, and the tissue is taken. Steve Charles described arcuate, C-shaped temporal arcuate retinotomy, because we know the nerve fiber bundles are arranged around above and below the horizontal raphe in a C-shaped fashion. So this kind of a retinotomy do not injure the nerve fiber bundle, and with the soft tip cannula, this retinal bridge is displaced nasally, so the horizontal diameter is reduced and help in the closure of the failed macular holes. So he has shown the closure and the healing of the retinotomy without scarring here, and there is no scotoma on visual field examination. Also, another procedure described is sparing the papillomacular bundle, the temporal half full thickness radial incision around one hole diameter from the edge of the macular hole. These relaxing radial incision also help in closing the failed macular hole. So we have already seen that some of the adjuvants like viscoelastic, autologous whole blood, autologous platelet concentrate. These help basically in prevent the dislocation of the transplanted tissue, be it ILM or capsular flap or whatever, helps in the acting as a scaffold and closure. So to conclude, the above described techniques prove useful, especially for large and refractory macular hole, which in the past had a poor surgical outcome. So these novel techniques reveal advancement in surgical techniques with better anatomic outcomes. So long-term visual outcomes have to be analyzed in larger studies. Thank you for listening.